frightened Miss Muffet away.
Poor little Miss Muffet. What she needs is a nurse who understands phobias, who can help her work through this. Maybe if she had you as her A+ nurse, she wouldn't have been so frightened by her phobia. Today, we're going to be talking all about anxiety and however that manifests, whether it's from a nursery rhyme to generalized anxiety to specific situation anxiety. And we're going to be talking about all the nursing care that's involved for patients with anxiety. But first, let's start with a very brief 1-minute introductory video to give you just a general idea of the concept of anxiety. So today's lesson on anxiety comes from just your Giddens text, chapter 32. As always, you'll complete your concept study guide on anxiety and answer the following questions as we go through this lecture. So take a minute to pause the video and write down these questions so that you'll be ready for them as we go. So what is anxiety? Well, it's a subjectively distressful experience, meaning it's something an individual feels, and it's hard to objectively or outside define it. An individual's distressful experience activated by the perception of threat, which has both psychological and physiological beginnings and expressions. So for little Miss Muffet, she had a psychological perception of threat by this cute little spider that had both psychological and physiological expressions. And so she saw the spider, her blood pressure went up, her heart started racing, she maybe had gotten sweaty and blotchy and red and was freaking out as that fight or flight response kicked in. And so she's both having the psychological freak out and a physiological change with her body. Now, the scope of anxiety can range from mild to moderate to severe and even panic levels. And at different levels, patients can be quite functional, or it can be completely difficult to function and disabling for a patient. And along that continuum, patients can definitely have fluctuations on where they're at. Now, certainly that fight or flight response can kick in where our bodies are trying to protect and either fight or flee. There's general adaptation syndrome, where the body sounds this alarm in stage 1 and then provides resistance in stage 2 and stays up and alarmed. And then finally stage 3, where the body's just exhausted and it can't fight anymore. And hopefully we overcome whatever that anxiety is before we get to the exhaustion stage. And then certainly there's brain structure or neurochemistry, and genetic makeup can predispose us to have more stress or feel the effects of stress and anxiety more than other people. Your Giddens text provides a really nice infographic on all the attributes of anxiety, including fatigue, arousal, which is a hyper state of awareness, panic attacks, which are on that higher end of the continuum of anxiety. Anxiety and worry can certainly go hand in hand. Phobia avoidance, so little Miss Muffet might never go sit on that tuffet again because she wants to avoid being around her phobia of spiders. Compulsions, where we maybe make poor decisions as the amygdala is producing that fight or flight response, and the logic or reasoning parts of our brains are not kicked in as much. We can have muscle tension or irritability, problems with sleep or concentration and fatigue because of that. And all of this stuff kind of plays together as the whole concept of anxiety. So anxiety can run from the spectrum of mild to severe or panic. And really mild to moderate levels of anxiety can have a positive impact and almost motivate us to whatever we need to accomplish that's causing that anxiety. But certainly severe anxiety to panic can cause injury to self or others. And sometimes it can even cause impulsivity to the point of suicide. And so we don't want patients getting to that point of severe anxiety or panic disorders. And there is interventions that we can do when patients get to that level. Now, there are a number of diseases that patients can have that have anxiety as a side effect or as a symptom of their disorder. Cancer, patients with cancer have a lot of anxiety over what their life outcome is going to look like and what quality of life they have left. Patients with different respiratory illnesses, COPD, chronic obstructive pulmonary disease, or pneumonia, can have anxiety because they have an air hunger. There was one time we were treating a patient who had come in who was a asthmatic and had pneumonia, and he was a big, strong, 6 foot guy who was very muscular, and we had like 6 or 7 of us in the room trying to get him into restraints and get him an IV because we knew that he was air hungry, and he was so panicked that he was just strong and moving and resisting us, even though we knew we were there to help, because he was so air hungry that he was having panic. And eventually we were able to get him controlled and then give him medications to put him to sleep so we could put a breathing tube in and save his life. But certainly respiratory illnesses at a severe level with hypoxia, low levels of oxygen, can result in air hunger and can make anxiety. And it doesn't even have to be to that extreme, but I think a basic physiological desire and need that we have is to breathe. And when that is not normal, that can be very distressing and cause anxiety for a patient. We can see dysrhythmias that either cause anxiety or are a cause of anxiety. Heart failure, hyperthyroid, which elevates kind of your whole system, and so you can feel anxious just because your metabolism is on overload. And then hypoglycemia. All of these things can be related with anxiety. So before you just assume someone has an anxiety-related disorder as a standalone, it could be that that anxiety-related disorder is actually related to some other medical condition. So what if our patients are most at risk for anxiety? Well, studies show us that people who have any kind of mental illness are most predisposed to have problems with anxiety. Certainly in general, there's more prevalence with females than males. And the peak of this is typically in middle adulthood, that 30s to 50s, those ages where they're taking care of their kids and also helping with their older parents, and they're in that sandwich generation. They have a lot of life stressors on them. They're still working full time, and all of those things can kind of pile up and cause greater levels of stress and also anxiety. Caucasian people tend to have a higher incidence than Hispanics or Blacks. And there can also be some genetic components to this, that we see familial patterns with certain anxiety disorders. So how would we know if a patient is having anxiety? How would we recognize this? Well, there's no real specific test to confirm anxiety, but we might want to detect some of the conditions that contribute to anxiety. So we would screen for those types of things, like the cancer, the hyperthyroid, hypoxia, those things that we talked about. But there are screening tools available that you can use to ask patients questions about anxiety. And your book provides a number of examples for you on page 315 on the bottom of the left column. So let's take a look together at Giddens page 315, specifically box 32.2, which is in the upper left corner. Go ahead and pull out your text. Pause this if you're not ready, because we're going to be looking through that together in our book. So what kind of things are we going to assess for patients with anxiety? Well, we want to know their medical history. Do they have any past medical history of anxiety or any other mental health conditions? Do they have any risk factors like the ones we just talked about? Any substance abuse issues? What are their current medical problems? Maybe those have something to do with it. And what kind of trauma exposure have they had? Patients who have had a history of trauma often will have more issues with mental illness as well, anxiety being one of those. So after we perform a medical history, we're going to go into their physical examination. So we're going to be looking for things like vital signs. And a patient who's acutely anxious, meaning anxious right now, is going to have an increase in blood pressure, and they may have an increase in their heart rate or their respirations. You're going to auscultate the heart and lungs. You're going to palpate the thyroid. You might do a neuro exam, and then you would draw some blood and some urine studies according to the doctor's orders. And the whole point of that, again, is not to diagnose anxiety, but to rule out other diseases that might actually be manifesting as anxiety. And then finally, you're going to do a mental status examination. And we'll get more into this as we talk about your mental health class that you'll take in the fall of your sophomore year. But things like, what's their appearance? Are they put together? Are they doing their ADLs? Are they taking care of themselves? Or are they disheveled? What's their attitude like? How's their behavior? What's their mood and affect? Is their speech clear? What's their thought content like? Are they having positive thoughts, or are they saying a lot of negative things, or are they spiraling into the same types of thoughts and it's hard to redirect them? What are their perceptions? Are their perceptions in line with what reality is? And how is their judgment? Does it seem like they're making good choices, or are they being impulsive? And so you see this nice image from your Giddens text as well that talks about how long the symptoms last and how intense the symptoms are will in fact impact the patient's ability, the functional impairment. So the stronger the symptoms and the longer they last, the more this is going to have an impact on the patient's ability to function. So things like concentration are going to happen at lower levels of symptom intensity or duration, where phobia and compulsions and panic attacks are going to happen as the symptoms are more intense and they last for longer. And so we want to kind of see where our patients are at with this anxiety, what kind of symptoms they're having, and how long they're lasting. So the question is, what nursing interventions or collaborative interprofessional interventions can treat anxiety? And the first answer is prevention. We want to prevent it before it gets to be a problem. And so that includes well visits across the lifespan to check in and see how an individual and the family unit are doing. We're going to get a thorough family history and see if there's a history of anxiety, depression, or other mental illness in the family. We're going to foster healthy family functioning. When you're treating a patient, you're treating the whole family unit, and you want to get a sense for the functionality of that family unit. And then we want to recognize early and refer often for anxiety-based symptoms to nip them in the bud before they get out of hand. And this can include both individual referrals or family counseling as well. Now, there are a number of medications and talk therapy that we use as collaborative interventions. Specifically for pharmacology, we use beta blockers. Beta blockers are beta antagonist receptor blockers. They're going to reduce a patient's heart rate and their blood pressure, which if a patient is having those physiologic symptoms of anxiety, it's going to help bring those down. And those are often also used for blood pressure, but we can certainly use those for anxiety as needed. We're going to start on benzos. The beta blockers end with LOL, always. Atenolol, pranolol, labetalol, it always ends in LOLs. And then you got your PAMs, those are your benzos, and those are sedative agents like Valium and Ativan. Those are the PAMs, and they are great at reducing anxiety. They're sedatives. but they also are habit forming, and they're not something that we recommend typically on the long term for patients. Some of our older patients may be on Buspar, which is a non-benzo anti-anxiety medicine. And then oftentimes antidepressant medicines can kind of overlap with anxiety and have some effects for these patients as well. And certainly psychotherapy, talk therapy is incredibly beneficial for many patients with anxiety. So the interrelated concepts for anxiety, certainly stress and coping, interpersonal violence, oftentimes domestic violence and family dysfunction can cause anxiety. And then mood and affect is certainly affected by anxiety in these patients as well. Finally, your Giddens text offers some exemplars, a basic simple phobia, like Little Miss Muffet, to a social phobia where patients feel afraid of social situations or how others might perceive them, to full-blown panic attacks, generalized anxiety disorder, which is like a lower level anxiety, but kind of all the time, and then obsessive compulsive disorders that we see as well. Many of these we'll dig into much more in detail in your mental health class. So just like Little Miss Muffet did not have any help for her social phobia or phobia of spiders, I should say, we need to make sure that we are giving our patients the resources they need, whether it's pharmacology, talk therapy, that we're equipping them with the resources, that we're screening early and intervening early if we're noticing any signs of anxiety. That's all. Have a great day.